Good morning YouTube, Stephen Chen back again with another video on the Derm exam, and today we're going to talk about reaction patterns. This is the sixth and final video in the Derm 101 series about the skin exam. As a reminder, we've already talked about the primary lesion, the secondary lesion, configuration, distribution, scale, and then this one's going to focus on reaction patterns, which is basically another way to bucket the different rashes that we might see in the skin exam. The way this works is that whenever you're faced with a rash on your patient, you want to think about which one of the 5 reaction patterns that rash fits best with. It's possible for a rash to fit with one of them, and it's possible for a rash to actually fit with multiple reaction patterns. And that's actually how we figure out what the differential diagnosis might be. In other words, if a rash is classically one reaction pattern, there's a specific differential, and if a rash might fit more than one, that actually helps us with a different differential. So let's get started. The first reaction pattern we're going to talk about is the papulosquamous reaction pattern. Papulosquamous, as it implies based on the name, just means that it's papular, meaning it's raised, and it's squamous, meaning there's scale. So papulosquamous just means it's raised with scale. It's a little bit redundant because, as you might remember from one of our earlier videos, if there's scale, you can almost bet that it's going to be papular or plaque-like, because if there's scale, it implies there's some type of elevation change. The other reminder is that whenever you see scale, it means that there's some type of epidermal involvement. So there is something going on in the top layer of the skin in the epidermis. So the classic rash that's perfect for papulosquamous is psoriasis. Psoriasis is usually described as salmon-colored plaques with micaceous scale, meaning that the color of the plaques is a slight reddish orangey hue, just like salmon might look like, and the micaceous scale refers again to the rock that's called mica, which looks like this silvery, flaky white scale. Psoriasis is the prototypical papulosquamous eruption. Other things also fall in the papulosquamous category, of course, and again, that means anything that's raised with scale. So this might include things like lichen planus. Secondary syphilis is classically papulosquamous as well. There's a lot of different things that can fall in this category, but that's our first reaction pattern. The second reaction pattern is a little bit tough to explain because the name of it actually just implies the diagnosis that we're thinking of, and that is eczematous. If something falls in the eczematous reaction pattern, it actually means that it looks like eczema. The confusing part about this is that eczema actually has 3 different stages. The first stage, or acute eczematous eruptions, actually look like a bunch of little vesicles that have just started to pop open, and you might see a lot of collarettes of scale. That's where you see little footprints of little vesicles that used to be there. And so this type of scale and this type of eruption might look a little bit wetter because there's been a lot of drainage. Dare I say the word moist. In subacute eczema, we start to see some more fissuring, some drying of that acute eczematous process, some more fine scale, and in chronic eczema, we start to see lichenified plaques. And remember, lichenification, which is a secondary change that we've talked about before, implies that there's been a lot of chronic scratching and rubbing in that area, usually from itch, and you see hyper-accentuated skin markings. If a rash looks like it's in any of those 3 stages of eczema, we call that type of reaction pattern eczematous. So obviously the most common cause of an eczematous reaction pattern would be atopic dermatitis or intrinsic eczema. The other thing that can cause eczematous eruptions would be something like a contact dermatitis, either irritant or allergic. There are also eczematous eruptions that happen because of drug. Just because something is eczematous doesn't necessarily mean that it's atopic dermatitis. There is still a broad differential when you see an eczematous eruption. The third reaction pattern we'll talk about is dermal. Dermal implies that all the action is happening deep. It's happening in the dermis, and for this one, I actually throw the subcutis in there as well. In other words, I think of this one as sparing the epidermis, but we use the word dermal to describe this reaction pattern. Rashes with a dermal pattern tend not to have scale unless they happen to have overlying dry skin or xerosis, but that's kind of 2 things coming together. Generally, a purely dermal rash will just have elevation change with no scale on top. The prototypical rash for this I think of is granuloma annulare. This is a reactive process that occurs in the dermis of the skin where you start to see these collections or granulomas of inflammation happening in the dermis, and classically there is no scale on GA. The other thing that I think about is something like a paniculitis which would be seen in erythema nodosum, erythema induratum, lupus panniculitis, all of those that have inflammation where the action is in the subcutis, in the fat of the skin. You're not going to see scale either, and usually instead you're going to see inflammation and some elevation change in some swelling and edema in the acute phase, and after that acute phase has resolved, sometimes it'll actually resolve with atrophic plaques. All right, we've gone through 3 reaction patterns. Let's move on to our 4th. Our 4th reaction pattern is the vascular reaction pattern. So when something is vascular, it implies that there is something going on in the blood vessels, obviously. And those things might be something like vasculitis, which is inflammation in the wall of the blood vessel, or vasculopathy, which means that there's something clogging up the vessel itself. Those classically give you some type of net-like retiform livedoid pattern. What this means is that you're starting to see the way that the skin is perfused come to life in the physical exam. The skin is perfused in these cones. Anytime you block a vessel that's leading to a cone of perfusion, you're going to start to see that circle of skin die off and necrose. And so as multiple areas start to necrose, the edges of that area might start to seem a little bit retiform or stellate, almost with sharp edges. However, you might not always see complete occlusion of the vessel. You might see some sludging of the vessel, you just might see some reversible changes, and in those cases we start to see something called livedo reticularis. Livedo reticularis, we've all probably seen before, is just this net-like pattern that we usually see on the knees, on other areas, and that's usually reversible and usually physiologic, but it can also be pathologic. There's a related rash called livedo racemosa, which is livedo reticularis, but the net isn't complete. There's breaks in the net, so there's these vascular hyperpigmented areas that just stop abruptly, and that, in our teaching, is always pathologic. Let's move on to the 5th and final reaction pattern, and that would be vesicobullous. This one makes the most sense. It's either vesicular or bullous lesion, so common things would be pemphigus or bullous pemphigoid. And remember that whenever you see something blistering, the first thing that we think about is what level the split's at. It's important to think about your physical exam as well as maneuvers you can do on the physical exam to help you with that. So for example, if you see a blistering eruption and the bulla are tense, they just sit there, they're not drooping in any way, then that would usually mean that you have a pemphigoid, or you have some type of issue at the basement membrane zone. Versus pemphigus, where you actually start to see flaccid bulla, where the blister actually starts to droop a little bit. And that's because it's pemphigus and the split is happening a little bit higher up in the epidermis. A good mnemonic for this is that pemphigus ends with an S, so it's more superficial, and pemphigoid ends with a D, which means that it's deep. Now remember, there's a physical exam maneuver you can do to help you with this, and that's called the Nikolsky. So the Nikolsky sign would be positive if it's a flaccid blister or higher up in the epidermis. And remember, a Nikolsky is done by rubbing laterally next to the blister to see if you can recreate the same type of blistering process. If you push down on a blister and it spreads, that's called an indirect Nikolsky, or an Asbo-Hansen sign. In pemphigoid, the Asbo-Hansen, indirect Nikolsky, and Nikolsky sign would all be negative. There is an important exception to this rule, and that is Stevens-Johnson. Stevens-Johnson would also give you a vesicobullous reaction. However, it's Nikolsky positive, even though it's full thickness epidermal necrosis. So that split is actually happening under the epidermis, and you're seeing denuded dermis underneath. And even though it's full thickness, it's actually Nikolsky positive because you're just seeing complete cell death, and it isn't related to antibody-mediated destruction of either the desmosomes in pemphigus or the hemidesmosomes in pemphigoid. Those are the 5 reaction patterns. So you can see how if a rash falls within one, then it's going to help you with the differential. And now let's use some examples. Let's say someone comes in with this rash pictured here. As you can see, this rash is classically papulosquamous. And so since it's papulosquamous, there are certain things on the differential diagnosis that are going to help me. Immediately, I know that I don't have to worry about things that perhaps are in the dermal category. This eruption probably is not something like granuloma annulare or erythema nodosum. Instead, this rash might be something like psoriasis, lichen planus, pityriasis rubra pilaris. And that's exactly what this rash is. This is PRP, pityriasis rubra pilaris. And so we're using the reaction pattern combined with the primary lesion, which would be these follicular red papules, and then scale, which shows us that we have this Branny pityriaciform scale, taken all together gives us that diagnosis of PRP. Let's do another example. Take a look at this picture, And you can see that in this picture, it's very classically vesicobullous. So since it's vesicobullous, we can pretty much take things out of the papulosquamous category. We know that here we're seeing tense bulla, and the primary lesion again is that bulla, and since they're tense, they have a negative Nikolsky, and immediately we can take things away. So things in the papulosquamous category probably are not causing this, meaning psoriasis probably isn't causing this. Syphilis, less likely, even though syphilis can cause anything. PRP, probably not causing this. Pityriasis rosea, probably not causing this. Instead, let's go to the vesicobullous category, and in the tense blisters and bulla, we can think about things in the pemphigoid group. Maybe this is linear IgA, bullous pemphigoid, cicatricial pemphigoid, and that's the appropriate differential diagnosis. This is actually a case of bullous pemphigoid, and we can again tell from the tense blisters with the negative Nikolsky. Of course, we probably do a biopsy or some blood tests to help confirm the diagnosis in this setting. Finally, let's talk about what happens when you have rashes that cross different reaction patterns. So take a look at this rash. So this rash, I would argue, actually crosses two different reaction patterns. We're seeing a lot of small vesicles, and all those small vesicles are starting to pop and perhaps leave collarettes of scale. So what we're seeing here is a combination of the vesicobullous reaction pattern as well as the eczematous reaction pattern in the acute phase. And so what this tells me is that when we see those two come together, it immediately triggers an acute eczema as a possible diagnosis. Now remember, an acute eczema is not truly a diagnosis. We need to figure out what the underlying cause is. So this could be an acute atopic dermatitis, an acute contact dermatitis, and that could be irritant or allergic. It could be an acute eczematous eruption to a drug, and that's for us to figure out based on the history. So you can see where a combination of different reaction patterns can also help you narrow your differential diagnosis. That's it for today on the reaction patterns. I hope that was helpful for you. As you can see, by combining information that I've taught you from the primary lesion all the way through to the reaction pattern, when you're faced with a rash, if you work through it systematically, you're going to hopefully come up with a very appropriate differential diagnosis and be able to whittle down the possible diagnoses based on the history from there. Thank you so much for joining me today. See you next time.